Cranial nerve 11 is a little bit different. It's not really a true cranial nerve. It's a spinal nerve that comes up and then goes back down again with some cranial nerves and gives a contribution to the vagus. It supplies sternocleidomastoid and trapezius, the same side to the nucleus of it. But sternomastoid has got a bilateral upper motor neuron supply anyway. But effectively, they act ipsilaterally to their nucleus. Above the nucleus, you've got that corticobulbar tract, which we talked about briefly before. And most of the cranial nerves get bilateral upper motor neuron, which we'll come on to later on. That's the tube map above the nucleus. So we'll pass on from that. If you've got lesions to the nuclei, they tend to be called bulbar lesions, and they cause bulbar palsy. If you get bilateral lesions above the nucleus, they cause pseudobulbar palsy, and if it's distal to the nuclei, any lesions are called peripheral lesions. So, testing. Olfactory nerve, nice easy one. You've got the nerves coming straight from the brain, fibres go through the cribriform plate of the ethmoid and have little sensors in that olfactory cavity there, and they are stimulated by smells. So if you want to test it, you can get the patient to close one nostril off and have a distinct smell with you, something common like coffee, polo mint, toothpaste, something like that, old socks, and offer that to the other nostril, can they smell it, and then reverse the procedure with a different smell and see if they can identify that. Don't use anything aggressive. Like, virtually every time you do this, someone says, can you use smelling salts? Not that you hear them anymore. But they were primarily ammonia. And ammonia the patient will smell it, but they're not getting it through the olfactory nerve, they're getting it through the pain receptors in the trigeminal nerve. So it's not much good for testing smell. It is good for testing whether the patient's lying or not. Because if you say, can you smell this mint? No. Can you smell this coffee? No. Can you smell this ammonia? No. You know they're lying. Again, I don't think it would be something we're likely to find as osteopaths, but certainly neurologists in hospital might find people trying to big up their insurance claim by telling them what they've lost.
So if you can't smell, you would always be able to smell ammonia?
Yes. Well, you would always be aware of the ammonia, but you're getting it because it's stimulating the trigeminal nociceptors rather than the olfactory epithelium. Optic nerve. That's the bit that goes from the back of the eye directly into the brain, and we can test various aspects of it. Acuity is how sharp your vision is. So you might want to use a Snellen chart, that's the optician's chart on the wall. You can print those off the internet and stick them up if you want to. If you wanted to get an accurate measure of the acuity, it's got to be the right distance away. If you're in an optician, you're sitting in the chair, they've got a projector up here, which projects onto a mirror in front of you and then comes back. And that is normally something like 3 meters away. So the total distance the light travels is 6 meters. And the size of the image is right for that size, and then what you can see, they can judge against the scale of how normal it is. The term 20/20 vision came, it didn't used to be 6 meters, it used to be 20 feet. And 20/20 was you could see at 20 feet what a person with normal vision could see at 20 feet. So hence 20/20 vision, which was supposed to be normal. If you look on the Snellen chart now, the normal one, there are more complicated ones, but the normal one, the second line up from the bottom is what they now call 6/6 vision, used to be 20/20. And the one under that, which is smaller, is 6/5. You can see at 6 what a normal person could see at 5. So in other words, that's slightly better than normal. The other thing that you can do for the optic nerve is colour vision. So you can use Ishihara charts, you know, those things with the patterns on that. If you've got normal colour vision, you can see an 8 or a 5 or something. And if you haven't got normal colour vision, you just see like a pattern. They're called Ishihara charts. You can test the visual fields, how good their peripheral vision is. All these are optic nerve tests for cranial nerve 2 on its own, and we'll come on to that in a sec. In the eye, you've got the retina on this side and the retina on that side. Light coming from the temporal. My vision, this is my temporal field, this is my nasal field of this eye. So light coming from the temporal field gets picked up by this bit of the retina and goes through there, crosses in the optic chiasm and goes into the brain there. And light coming from the nasal field comes around this way, doesn't cross in the chiasm, comes on that side of the brain. So you get this optic chiasm, and if there's a problem there, which you can get with a pituitary tumour, it can give you tunnel vision in the sense that these nerves are affected, which are picking up the information from these bits of the retina, which are the information coming in from that side, so you can only see in front of you. So different points, if you break there, it's different from breaking there, and it's different from breaking there, and you can see the effect. That's normal vision, right there. If the optic nerve is cut completely there, then you get normal vision on that eye and no vision on that eye. That's blind in that eye, anopsia. In the chiasm, you've got bitemporal hemianopsia. So you've lost the lateral temporal side of your vision. And if you get it cut there, where you get one that's crossed and one that hasn't crossed going through, you get blindness there and there on the same side of each field of vision.
What about when a patient has a migraine and they just lose the lateral field of one eye?
I don't think that's to do with the nerve itself, it's to do with the way the brain is interpreting the images from the eye. Because a lot of this, like I was saying before about all the stuff that goes on in the background, we're talking about the pure optics here of light going into the eye, through the eye, and through these sort of electric wires into the brain. Once it gets in the brain has to interpret it, and that's incredibly complicated. So I think the effect of the migraine is to interrupt the brain's processing of that information. They're the Snellen chart, which I talked to you about, the Ishihara charts, which I talked to you about, so I'm done with that. Accommodation, this is where you're testing 2 and 3 at the same time. If I focus into the distance, my eyes are looking more parallel and my pupils open out a little bit. If I have a target and bring it towards me, as I focus on that target, the eyes kind of move in like that. The lens size changes, the the lens shape changes and the pupil size changes. The pupil gets a bit smaller as you come in closer, as the eyes come in, and all this works together. And that is called accommodation, and it allows you to focus closer. When you're young, you can focus very close. As you get older, the lenses don't deform as much, so you can't focus as well. I had a medical once, and they put a pair of optician's glasses on me with a kind of raw thing coming out there with a target on it. And he said, focus on that, and I'm going to bring it towards you and tell me when it gets blurred. And it came in, and I said, okay, got blurred there. And he read my age off the side of the scale. Luckily, he got it right. So that was it. But as you get older, you lose the ability to focus closely. And that's called presbyopia. That's why you need reading glasses when you get over about 40.
You know what, sorry, just move, did anyone do the sausage? In between the fingers? No. Tea break.
That's the accommodation. It's showing you how the lens changes in shape to accommodate near or far targets. And if you lose the flexibility in that lens, it doesn't look good. The other thing that we can do to check the optic nerve is the size of the blind spot. If you look at the way the optic nerve comes into the eye like that, this area here hasn't got any light receptors on it. The nerves, when they come out to form the retina, that's where all the light receptive cells are. But any light forming on that bit doesn't register, so that's the blind spot. And that tends to be coming in at about 12 degrees, 12 to 15 degrees like that. The light goes right onto the blind spot. So what you can do is get the patient sitting face to face with you, arms width apart, and bring one of those medipins in across from the side. I cover my eye, the patient covers the opposite eye, my left, his right eye, and we look here, looking into each other's eyes, but being aware of the peripheral vision. Out here, you either don't see it or you see it in blackish, dark brownish, and then as it comes in, you can see it as red when it leaves the rods and comes into the cones, and then when it gets about 12 degrees off, it disappears, and then it comes back again. And what you're doing is comparing the disappearing for you as to when it disappears for the patient, and then when it comes back. If the patient loses it before you do, gets it back after you do, then their blind spot's bigger. Therefore, you think there might be a problem with perhaps the fundus papilledema or something like that.
Yeah.
It's tea break. Should we carry on after tea, or do you want to go?
You want a break?
Yes.
Yeah?
Keep going.
Keep going?
Okay. So that's just what I've set up there. Sit facing patient. Eyes level, arms length apart, cover your right eye, patient covers left eye. Bring the medipins globe horizontally, lateral to medial, along the equator of the eye, so halfway along the eye and about halfway between us. And initially seen black, then red, then it disappears, and then it reappears. And you want to know whether the distance obtended is the same for the patient as it is for you. If the patient loses it before you and gets it back afterwards, their blind spot's big compared to yours. If yours is all right, then chances are there's something wrong with them. And it may be increased intracranial pressure, or it may be inflammation or infection or something at the end of the optic nerve. And if you were to look into the eye with an ophthalmoscope, you might see the fundus sort of swelling and being a bit enlarged. consensual light reflex. This is testing cranial nerve 2 and 3 together. If you shine a light in one eye, both pupils should constrict. And then if you take the light away again and shine it in the other eye, again, both pupils should constrict. If that doesn't happen, then either the afferent supply, the eye's not seeing the light and taking it into the brain. What happens on these things is that one afferent signal going in the brain from one eye causes two efferent signals, so that both eyes are affected by the efferent signals. So if you shine it in and nothing happens, it may be that that light's not getting to the brain at all. If you shine it in, one eye responds and the other doesn't, it could mean that the efferent signal in cranial nerve 3 on the eye that isn't responsive is a problem. Or, of course, there could be processing problems within the brain. But effectively, that's what you're doing on there. Eye motion, the H test. So you're going to have you're facing the patient, hold your finger or a pointer of some sort in front of them, ask them to keep their head still but follow with their eyes, and you're going to ask them to tell you whether at any point they see double vision. And you move in a kind of H pattern. Roundabout, you don't need to go past the patient's shoulders. If you make the patient's eyes move more than they're designed to, you'll give them double vision anyway. So if you just take it about shoulder width apart, up and down, and then back and up and down, you can look at what their eyes are doing, and you can see whether they're moving as they should. You can see whether there's any kind of nystagmus being triggered. But if you ask them if there's any double vision, if at any point they see two fingers instead of one, then you know that one of the patient's eyes can't look in the direction that you made them look when you provoked double vision. Effectively, each eye produces its own image, like a camera. If they're moving, both eyes follow, and the images stay in step. If you get a point where one eye is following it and the other eye can't go there, then the images become too different for the brain to map as a single image, so it snaps it into two. The brain can cope with them being slightly different because they are because of where your eyes are on the side of your head. But if they're very different, the brain reverts to giving a separate image for each eye. So if at one point you find that you've got double vision, it means one of those eyes can't look in that direction. So you then, if the patient tells you that, then you get the patient to cover one eye and one image will disappear. You need to explain to the patient that their field of vision is like a big circle, and one of the images is going to be near the edge of the circle, and one's going to be near the centre of the circle, either side by side or like that or whatever. But if the circle's radius on the patient's nose, one's going to be nearer the nose and one's going to be nearer the edge of the circle. And the rules of this are that the lateral image, the one that is near the edge of the circle, is always the false image produced by the faulty eye. So if we cover this eye and the lateral image disappears, we know that this eye was the faulty one. It can't look in that direction. If you covered this eye and the medial image disappeared, it's telling you the same thing. We're looking through the faulty eye. So you interpret that by finding out which eye can't look in which direction, and then work out which cranial nerve is causing it. And there's a kind of postcode or chemical formula that says LR6 SO4 3. So LR, lateral rectus, and that is cranial nerve 6. SO, superior oblique, which is cranial nerve 4, SO4, and all the rest are cranial nerve 3. Now, lateral rectus makes the eye look laterally, so it makes the right eye look to the right, or the left eye look to the left. So if the right eye can't look right, there's a problem with lateral rectus or cranial nerve 6. Superior oblique makes the adducted eye look downwards. So if you get a problem with the eye looking downwards, the chances are it's the superior oblique on that side. And that is cranial nerve 4. All the other eye movements are controlled by cranial nerve 3. So if you were to lose cranial nerve 3, the patient's eye on that side would be looking down under the influence of superior oblique and out under the influence of lateral rectus. So it would be looking down and outwards. So if you see a patient whose eye is looking down and out, you can say they're cranial nerve 3 has...
Is that because the cranial nerve 3 takes it inwards, so you lose that, so it's still going down but out?
Cranial nerve 3 supplies all the other muscles which do all the other movements. So if you've lost those, the only ones you've got left is superior oblique pulling it downwards and lateral rectus pulling it outwards, so it kind of goes down that way. The H test, and that's up there. I think that makes it more complicated than what I said, actually. So I've just said all that, haven't I? Yeah. Lateral image is false produced by the faulty eye. Trigeminal nerve is quite complicated. It's got quite a long nucleus, and various bits of the nucleus does various things. And there is also quite a complicated ascending pathway for that. But from the point of view of testing, we've got motor and reflex, and we've got sensory issues. So motor, you've got muscles of mastication, so the test would be to observe the patient opening and closing the jaw and lateral deviation of it, and can they do it against resistance? There are a couple of reflexes, but they're not normally tested for these reasons. The jaw jerk is an odd one. When we talked about say the biceps reflex, we stressed the biceps. That produced that reflex arm which contracted it, and the tapping on there made the muscle work. With the jaw, the same thing doesn't happen. It should do on the face of it, because by stretching the muscles, you're producing the same effect. But if you think about it, from a survival point of view, you wouldn't want that to happen. Because if you bit down on something hard, the response would be to make you bite down even harder and damage your teeth. So that reflex is inhibited from above by the upper motor neuron circuitry from that. And because, as I said before, the upper motor neuron supply of cranial nerves are bilateral, you get each side gets this, its upper motor neuron supply from both sides, then that inhibition stays as long as you've got a single upper motor neuron on the trigeminal nerve there. So if you were to try and test the jaw jerk by putting your finger across there and hitting it like that with a patellar hammer, you wouldn't expect anything to happen. If you did get the teeth suddenly snapping closed, it means you've got a bilateral upper motor neuron lesion of the trigeminal nerve. So A, we don't bother doing it because it's a bit invasive, and B, it's a very rare condition, and it would be fairly obvious that you had it anyway without testing it. So the reflex is there in theory, but not in reality. The other reflex, which we don't normally do, is associated with the cornea, with the trigeminal nerve, is the corneal reflex. The cornea is the transparent covering over the iris and pupil of the eye. So if you wanted to test the corneal reflex, what you can do is get a piece of cotton wool, tease it out into a strand, and then out of the patient's eye line, touch the cornea with the end of the strand of this cotton wool, so they can't see it coming. If they see it coming, they'll blink anyway. But if you touch it on there, it should make the eye blink. And one touch on one cornea should make both eyes blink. Like before, one input causing two outputs. But we don't normally do it for two reasons. One, it's a bit invasive. You don't really want to go sticking cotton in people's eyes. And the other thing is that it's not very reliable, because with contact lens users, because they're used to putting contact lenses in their eyes all the time, they kind of override that reflex. It doesn't work for them anymore. So again, it's one that is there which we don't normally do. So motor in trigeminal is really power testing of the muscles of mastication. Sensory, you've got the three branches of the trigeminal nerve, V1, V2, V3, the ophthalmic, the maxillary and the mandibular, and you can test with light touch, pinprick, temperature, just as you would do normal sensory testing. If there is a lesion in the cranial nerve nucleus area, you can get a deficit in like a target distribution around the muzzle area, around like that. So if the deficit is nearer the centre of the muzzle area, if you can't feel that, it's more likely to be in the upper part of the nucleus. And the more lateral the defects, the lower down the nucleus the lesion's likely to be. But that's if it's effectively a bulbar lesion. From the normal peripheral lesions, it's just whether you've got the normal sensation testing in those areas there. So that's trigeminal nerve. Facial nerve, there's a mnemonic for this: face, ear, taste, tear. Face, muscles of facial expression. So testing it, can the patient screw their eyes up, smile, blow their cheeks out, wrinkle their nose, lift their eyebrows, all those sort of movements. Can they do it, and is it symmetrical? Ear, it supplies the stapedius muscle in the inner ear, and that's a bit like the left-hand pedal on a piano. It softens, it dampens down the noise. So normally the hearing is muted a bit by the action of stapedius muscle. And if the nerve supply to stapedius isn't there, then sounds might sound louder in that particular ear. It's also got some supply to some of the muscles around the hyoid area, but we can't really test them very easily. And the tear bit is it supplies the lacrimal gland. So if the patient's got dry eyes or some kind of incorrect amount of tear fluid, that can also be related to the facial nerve there. So face, ear, taste, tear. And from a sensory point of view, it provides taste to the anterior 2/3 of the tongue. So it could be tested if you wanted to. You would need to have a dropper or a Q-tip or something with the different tastes: sour, salt, sweet, bitter and umami, and see whether you can pick those tastes up if you wanted to. We wouldn't normally do that as osteopaths. Neurologists might do, but we don't normally do that. So that's facial nerve. The interesting thing about the facial nerve, or one of the interesting things, is that you've got this dual innervation of the upper part of the face. So if you've got this side of the brain and that side of the brain, both give a supply to this part of the upper face there. So if you've got a lesion here, an upper motor neuron lesion, you would lose that. You would still have that supply there, and you would still have that supply there. No, sorry, that's not both of those there. You don't have that supply there. If it's an upper motor neuron, you lose the lower part of the opposite side of the face. If it's that's an upper motor neuron. If it's a lower motor neuron, the lesion's there and you lose both sides of the same side of the face. So because of that dual supply, on that one, you've still got supply there from there, but not from there, and you don't have a supply here from there, so you've lost that part of the face. But on this one, you've got the dual supply to the upper bit, and you've only lost that bit for the lower one there.
So you lose both of the facial, you lose the whole half.
On this one, you lose the whole half of the face. With this one, you lose the lower quarter of the opposite side of the face.
So even though it looks more dramatic, it's actually better to have the lower quarter.
Possibly. And that's an indication of where the nerves come out, supplying the facial nerve, different branches of it there. So motor testing, really making them pull faces against a bit of resistance. And samples of each taste and drop it on the tongue if you wanted to do it. There's also a test of lacrimation, which is a bit complicated. You've got all these lacrimal passages where the tears can drain away, but the gland itself is producing that fluid, and it's innervated by the facial nerve. And if you wanted to, you could use a bit of filter paper into just under the eyelid there, and over a period of time see how wet it gets compared to the other side. I mean, again, we wouldn't normally do that. A neurologist might do. And again, that's really just to say the standard thing, that there's a lot of interconnections that aren't immediately obvious that are going on with these nerves, where they're linking up all sorts of other things in there as well. Vestibulocochlear nerve 8, you've got a hearing bit and a balance bit. If you've got a if we look at the hearing bit first, this gives us a limited idea, a way of doing a kind of hearing test on the patient. It is a bit limited though, and if you need any kind of sophistication in a hearing test, you really need to send them to an audiologist, where they will play specific frequencies at specific volumes and kind of map out the response. But if we just wanted to get an idea of what their hearing was like, you could say, can you hear that? Can you hear that? If your patient can say yes to both of those, even if they're telling you they've got a hearing problem, there's not much you can do about it, just refer them on. If you can hear that, but you can't hear that, now we know that there's a deficit, and we know that the deficit is in the right ear. So if we wanted to, we might be able to decide which type of hearing loss this was related to. And we can do that by using a tuning fork. Can I borrow that tuning fork again? You would normally use the small one, but it doesn't really matter now because it would be, that will do for example. But this is the one for vibration. Yeah, we would normally use the small high frequency one. But suppose I was to ding that and put it on your head, and if I said, can you hear that? I would expect you to say yes. I might in fact put it on the front part of the head. If she's got a lot of hair, then that would act as a kind of padding. In my case, it doesn't matter, but with somebody, you might put it on the front of the hairline. Now, what's happening is the tone that you're making with that is propagating through the bones and stimulating the nerves in each ear. Okay? So I would expect you to say, yes, you could hear that. Let's do it there for you. And then I would say, can you tell me where the sound's coming from? And if you were perfectly healthy, you'd sort of look at me strange and say, well, it's pointing the chin, it's coming from that. Or you might say, it's all around me. Or you might say, it's inside my head, or something like that. What you wouldn't normally say is that it's in my right ear or my left ear. But if we had a problem, which we've already found that there's a deafness in that ear, if she said that, yes, I can hear it, and it's coming from my right ear, then I can say, right, the deafness that we found in your right ear is a conductive deafness. Now, conductive deafness is, think of looking through the ear canal, you come to the tympanic membrane, beyond the tympanic membrane you've got the little chain of ossicles, and that goes right into, right up to the cochlea, okay? Anything in that pathway that interrupts the passage of sound is a conductive deafness. That could be a peanut in the ear, it could be wax, it could be infection, it could be a torn or ruptured tympanic membrane, it could be a problem with one of the bones in the little ossicles, it could be arthritis in those. Anything that interferes with the passage of sound vibrations through there, right up to the cochlea. And now we could include things like glue ear, mucus build up in there, infection in there. Any of those would class as a conductive deafness. Right up to the cochlea, where it becomes into the nerve. If the nerve is gone or faulty, then it becomes a sensory neural deafness. Okay? Now, if on this case, the vibration of that test was heard in the bad ear, then we could say that it's a conductive deafness, that effectively the nerves are right in that ear, but there's something in the mechanical pathway that's affecting it. However, if we did it and she said she got it in that ear, we know that from the easy test that the problem within the right ear, this doesn't now mean she's suddenly gone conductively deaf in the left ear. It means that the deafness that we found before in the right ear is a sensory neural deafness. And the reason she's hearing that in the left ear now is because that's the only nerve she's got left to hear with.
Why would she hear it louder in this one if it's...
Good question.
Why wouldn't she?
Let's do an experiment, okay? All together, I want you to hum and put your finger in your ear and out a few times. One at a time. Does everyone convince themselves that when they do that, when they put the finger in the ear, the sound goes to the ear?
Yeah.
Okay. So what you've got to imagine is that you're the little operator sitting in the brain with all the controls, light coming in from the eyes, sound coming in from the ears. Okay. You suddenly lose sound from one ear. What are you going to do? You're going to turn the volume up on that ear. And you still can't hear it, so you turn it up a bit more. If someone suddenly finds a back way round, that volume is going to sound loud. And that's what we're doing there. We're sending the conductive pathway through here is blocked. So we're sending the vibrations through the bones to stimulate the nerve on that side, but the gain is turned up on it by the brain. So that's what tends to happen there. It's monitoring what it's expected to hear, and if it can't hear it, it tries to amplify. So
If you haven't got the nerve there, it's automatically goes like
well, that's the only nerve you've got left to hear with, so we can do that. So that test is called Weber's test or Weber's test, depending how continental you are. And that is, the books will say the sound of the tuning fork on that test will localise to the side of conductive deafness, which is perfectly true, but you need to interpret it. It doesn't mean that the sound that it goes to is conductively deaf. It means that if you have a conductive deafness, it will go to that ear. But if you don't have a conductive deafness, if the deafness is sensory neural, then it will go to the other ear, because that's the only nerve you've got left to hear with. The other one that you could do with a tuning fork is called Rinne's test, and that is applying the tuning fork to the mastoid. And this is a bit, it takes a bit of patience, this, because it seems to go on forever. What you do is ding the tuning fork and put it on the mastoid. And can you hear it? Yes. Tell me when it stops. And with this, it goes forever. With the smaller one, it still goes on for ages and ages and ages. And then they say it stopped. And then you quickly do that. And then you say, did it come back again? And they say yes. And what that's proved is that the hearing is normal in that ear. What it's saying is that you can hear better the way you should hear through the air canal than through bone conduction. So when the tuning fork has run out of power to be able to push it through the bone, without re-energising it, just by turning it round, it's still got enough power to push the sound through the air canal. So air conduction is better than bone conduction, so the ear's normal.
That means there's no difference.
There's nothing on there. If you had an ear where bone conduction was better than air conduction, then you could say there's a conductive deafness in there, because it goes around the shortcut rather than the way it should do. And if neither of them worked, then it's a sensory neural deafness in there. Okay? 2 tests using tuning fork, Weber's or Weber's and Rinne's. Both give you the same information. There's no point in doing both of them unless one's equivocal. Probably the easiest one to do is Weber's or Weber's, because it gives you a kind of quick answer. The Rinne's one you do have to leave it there for ages for it to run down. The one about the vestibular apparatus is the normal one that we use is the hornpipe manoeuvre, where you have somebody sitting down. Suppose they're sitting like that. If you look in the books, they show you dropping the head off the end of the couch and turning it to the side. So from sitting straight up, they drop back, head turned to one side, and you look at their eyes to see whether there's any nystagmus going. And doing it that way would test my left ear, doing it that way would test my right ear on that. It's a bit of a nasty test to do, because if you do have a problem with that apparatus, doing that movement is likely to make you feel nauseous or actually sick. So be a bit careful if you're going to do it, unless you've got a mop and bucket handy, and stand out of the way. But yeah, that's the Hallpike manoeuvre, or sometimes you see it as Hallpike-Dix manoeuvre. But you're looking to see if you provoke nystagmus. Sorry about this. It'll go off in a sec.
Trevor, what would cause the cranial nerve 7 palsy? What would cause that conductive
Sorry.
sensorineural deafness?
Do you mean the sensory neural deafness? Yeah. Well, it could be an infection in the air, any kind of damage to an area of the brain which affects that nerve, or the nucleus of that nerve, will cause it. I mean, typically you get bleeds or clots or something like that. It may be that the nerve is being interfered with on part of its root. You know, you get it going through particular areas that might be kind of tweaked a bit. But it would be difficult to say without imaging exactly what happened to it. But something on its pulp affected it. So that's the 8 in terms of balance and hearing. 9. Done all that. Oh, there is, again, in the hospital, they can test that by squirting cold or warm water in your ear and seeing which way your eyes move. Again, we wouldn't normally do that. 9 is the glossopharyngeal. That gives sensation to the back part of the throat, the pharynx, and the tonsils and that sort of area. It also is sensation to the middle ear and taste to the posterior third of the tongue. You recall 7 gave taste to the anterior 2/3. We don't normally test this on its own, although you could by doing taste into the posterior third. We normally do it in conjunction with cranial nerve 10, the vagus nerve, because the vagus nerve does a lot of things, but one of the things that it does is controls the muscles at the back of the throat and at the epiglottis. And what you can do is use a long, thin stick, they call it an orange stick, and if you get the patient to open their mouth, shine a light in there and touch the orange stick to the side of the back of the throat. That stimulates cranial nerve 9, which sends a signal, an afferent signal up into the brain, and then you get an efferent motor signal coming out on the vagus nerve, cranial nerve 10, which actually tenses the muscles up at the back of the throat. And if you look at in the top, the arch of the palate has got a kind of seam along the top. And the tensing of those muscles under the influence of the vagus nerve would pull that up. And if both vagus nerves and all the muscles are working right, it moves up in a straight line. If it doesn't move, then it may be that the cranial nerve 9 isn't sending the afferent signal. If it moves and it's pulled over into one side, it means one of the signals on 10 isn't stimulating the nerves on that side. So it would be pulled towards the muscles that are working. It would be pulled towards the strongest side and away from the lesion. So if you imagine that you've got something like that, if you pull both those leads at the same time, that will move up in a straight line, yeah, like that. If only one of them is working, it will pull off to one side. So that's what you've got in the effectively in the muscles at the back there. So you can look in the back and you can look at the midline seam at the top, or you can look at the uvula, which is that dangly piece of stuff at the top of the throat. The problem is not everyone's got a uvula, but the uvula should go up in a straight line or be pulled up. If they haven't got a uvula, you can just look at the midline rate of C. Okay, so that's testing 9 for sensation and 10 for power at the same time. The other thing that you can do for 10 is you can get the patient to cough. If you cough, there's normally a sharp cut and it cuts. That cut is the epiglottis closing under the influence of the vagus nerve. If the vagus nerve isn't working, you don't get that sharp cut-off, so you get a cough become like that, which is called a bovine cough. So you might find that, or hoarse voice, those sort of things. Are the superficial things that the vagus nerve might be involved with. But bear in mind the vagus nerve does a lot of work in terms of heart rate and digestive process and God knows what else as it goes all the way through the body. So there'll probably be other symptoms of that as well. But from our point of view, 9 and 10 tested together. I've said all that. Spinal accessory nerve is, as I said, really it's a spinal nerve that goes up and comes back down again with some cranial nerves. So it's not really a cranial nerve as such, but it's classed as one. And you test it simply by doing power testing on sternocleidomastoid and trapezius and if you get weakness on the same side, it's a peripheral nerve. If you get weakness of sternomastoid and the opposite trapezius, it's an indication of an upper motor neuron that's on the side of the sternocleidomastoid. But simply, it's just a power test of trapezius and sternocleidomastoid. And then you've got 12, the hypoglossal, which is simply the muscles controlling the tongue. So ask the patient to open their mouth and just observe the tongue resting in the floor of the mouth and look at it. Is it symmetrical? If one side's wasting, possibly fasciculating, that shows a lower motor neuron lesion of cranial nerve 10. If you get them to stick their tongue out, it should push out forward in a straight line. If it doesn't push out forward in a straight line, if it deviates to one side, this is kind of similar to what we've just had with the cranial nerve 10, but the muscles of the tongue act as we know, muscles work by pulling, they contract and pull, but the tongue muscles look as if they work by pushing, the way they're set up. So if the cranial nerve points to the left, if the tongue points to the left as it's pushed out, then it's being pushed to the left by the muscles on the right. So it's pointing away from the lesion. Sorry, it's pointing towards the lesion. I'll say that again, because I messed it up. If they're both pushing it equally strongly, it goes out on a straight line. If the left side is weak, the strong side will push it towards the left, and it will point towards the side of the lesion, which is the opposite way round from the one that I told you about, the cranial nerve not pulling up. So with the tongue, it should go out straight. If it goes out sideways, it's pointing towards the side of the lesion. And with the cranial nerve 10, it should pull up straight. If it pulls up to one side, it's pulled towards the strong side and away from the lesion. Okay? So that's done all the cranial nerves.